I can say that it is a wonderful experience to have Simran Singh back in Toronto with us. Simran was a fellow of ours going back a number of years now.
Yeah, it's getting there.
And Simran, where are you? We're at the, sorry, I should say we're at the Toronto course for congenital and structural heart disease in Toronto. And Simran was on the faculty of this year's meeting. And we're just going to have a brief discussion about education, training ACHD cardiologists. So Simran, why don't you tell me where you're based and what you're doing now?
Absolutely. So Eric, first of all, thank you for the invitation to be here. It's been an absolutely fantastic meeting. Since I finished with you, I've been at Weill Cornell Medical College in New York City at New York Presbyterian Hospital, and that's cross-appointed between Cornell and Columbia. There I focus on adult congenital heart disease, the clinical side, and then congenital and structural heart interventions. Most recently, I've started doing a lot more of the cardiology fellowship education as well. I'm starting as the director of the cardiology fellowship program. So that's where I've been the last 5 years since I left.
So a major issue really of, if we look at kind of trends in intervention, what we're doing is clearly becoming more complex. Mm-hmm. More complex interventions, more complex lesion subsets, and there's an issue with the workforce that we have and how they're trained, because people are really very silo trained.
Yeah.
And it's hard for them, or it's hard for people to have the expertise they need to tackle things that are being done. I was wondering if you could speak to how institutions overcome that and how we train people in that vein.
No, I think that's an extremely important question, especially as we're getting the population of ACHD and the number of ACHD clinics are growing in the US. There is a sector of who is best suited to care for these patients, and I think the answer is that it has to be a collaborative approach. I think the model that I observed and learned when I was here in Toronto between you, Mark Austin, Lee Benson, that adult pediatric synergy which works brings the experiences of both worlds into optimal patient care. And actually at Cornell, that's what we're trying to do. We have Ralph Holzer, who has joined us from pediatric interventional cardiology, along with our interventional team that crosses between Columbia and Cornell from pediatrics. And I think between them, and we're trying to do more and more collaborative cases together so that we combine that structural and congenital heart disease experience. I think that is the key for best patient care, and I do think as we move forward, hospital structure and even payment models will start recognizing that that is what's most effective for caring for patients, and so they'll start looking into that as a model of how to do it.
So it's interesting. I think our program has always been based in adult interventional cardiologists who does congenital heart disease.
Yeah.
But there are so few places where you can actually have that kind of footprint, because usually programs are run by different groups of people and you don't cross over between groups. There's clearly an identified issue in the United States in that the population is huge. It's been described as a tsunami.
Right.
And the places to train are very limited, where you can actually pick up the volume and the skills you need. And I agree with you. I mean, give me an example of where, and we talk about heart teams as being very in mode now.
Yeah.
This is a totally different heart team. This is not a surgeon and a cardiologist.
No.
This is a pediatric interventional cardiologist and a structural or an adult interventional cardiologist working together. Give me an idea of what that looks like, what type of lesions you would do together.
Yeah, I mean, I think a lot of the collaboration is the intellectual part as much as the doing the cases. It's both. It's the planning, it's the thought process of when and how to approach a case. I think in the US, there are a lot of people coming out with structural heart training, and there's a little bit of disconnect because not all structural heart is congenital and not all congenital is structural. So there's clearly overlap and synergy, but you're getting a lot of variability in what people are coming out with training. So I do think that having a collaborative atmosphere allows you to account for that lack of experience in training, where you can get you can use the combined strengths. So to give an example of the types of cases that we're doing together. So we're doing, when it comes to a complex Fontan who has a stenosis of the IVC, has an aortopulmonary collateral that needs to be closed together. We'll sometimes do those together. On the flip side, for any sort of pulmonary vein stenoses cases, either iatrogenic or congenital, we'll do those together. Pulmonary valve cases with percutaneous pulmonary valve, I think that's the most obvious example where that pediatric and adult synergy comes into place. And that's a good example of where the adult TAVI pathway is a little bit different, I think, in the training subset that's necessary for percutaneous pulmonary valves. I don't know if you'd agree with that or not.
I do, and I think it's also so important that institutional models facilitate that type of collaboration, because, and I think also reimbursement needs to follow.
I agree.
That type of pathway, because oftentimes it's like we are letting, physician payments and ownership of patients and those types of issues control or limit our ability to collaborate and work together to really provide optimal outcomes. And I think the heart team, the cat's out of the bag. Do you know what I mean? Like, you're not going to be able to stuff that back in. People are going to need to work together for the betterment of care.
Absolutely.
And that's the way it's going to go. I wanted to ask you a question about, it's very interesting because you were a mentor to one of our current fellows who ended up in Toronto for training. I wanted to know what advice you would give somebody who's finishing cardiology, thinks they know the direction they want to go in, and how you would guide them as to what they should be looking for, and where do you think the future is going for interventional structural congenital adult cardiology?
Yeah, I mean, I think depends where you're coming at it in your training. So if you're in a program that has a lot of adult congenital heart disease exposure and a lot of adult congenital heart disease experience versus one where you're just reading about it in textbooks, that's a different pathway altogether. I do think that, and we've been talking about this a little bit in SCI meetings and also in the CHD Council and ACC, what is the optimal way to get trained to do ACHD and ACHD interventions? I do think that the future will have a pathway that includes both clinical ACHD training. I don't think if you don't know the knowledge, doing the procedure itself is not enough.
Absolutely.
I do think that having the knowledge, you also have to have technical skills, which is obviously crucial in our field. So having a solid foundation in basic interventional skills from a pediatric or adult pathway, and then specialization in fellowships such as yours, where you focus on congenital and structural interventions. But I do think that is a relatively long road, but I'm a believer that we shouldn't be curtailing the road at the end of it. We should be thinking back at maybe in the years of medical school maybe, or even internal medicine residency or general pediatrics residency, about curtailing there, as opposed to cutting out what's the most crucial part of your training later on.
Do you think that coronary intervention is married to the ACHD role, or can you do the ACHD without having a coronary background? You mentioned pediatric cardiology is okay. The reality's been in practice now for how many years?
5 years.
5 years. So you have some insight into how that actually looks. Train some people.
Yeah.
What do you think about that?
I think it's funny because going through an adult PCI year, as we call it, it's not just a PCI year. It's a year where you learn large vessel access, you learn about closure devices, you learn about hemodynamics, you learn about how to manage shock, how to manage very sick patients. There is some inherent benefit to that with wire skills and catheter skills and stents and understanding the basics of how a cath lab works. There's an inherent advantage to that, whatever field in interventional cardiology you go into, including pediatric or ACHD interventions. Do I think it's absolutely crucial? No, I don't think so. I think they're amazing, outstanding pediatric interventionalists who do adult congenital interventions and historically have been the ones doing it. So I think you can go through either way. It's just about finding the experience base. If you are coming from a pure, but you do need those catheter skills. And I do think if you're coming from a purely adult pathway and have done ACHD training, I do think there is an inherent benefit for the extra year of doing an adult interventional cardiology fellowship before moving on to a structural and congenital fellowship.
I couldn't agree more. I think that, and it's been our experience that, when we train people who in ACHD intervention without that foundation, those foundational
Right.
aspects, it's really a tough year because, it goes very quickly. You're stuck on access issues. You're stuck on basic angiography issues. In ACHD, every case starts with a left and right heart cath, and if you can't pull that off in 2 minutes,
Right.
you got a problem.
That's
you know what I mean?
exactly.
Because every case starts the same way.
And then your learning is less. And so then you'll
Yeah.
be less confident coming out doing it. No, I mean, we should not be cutting time at the end of our training, because that's where it's the most crucial.
I think you're 100% right, and I also think that for the people training, although it seems like you're training forever, it's not your early years of training that actually matter. It's those
Exactly.
last few years, and it's where you finish your training, not where you start.
That's
the
right.
place to kind of make financial and intellectual investments is really at that very end, especially for people who are going to be quite subspecialized and quite rare.
Exactly.
I think we're going to wrap it up.
Right.
It was amazing having you. It's always 110% from you, whether it's in the lab or giving a talk or running our Jeopardy session. And
I learned it from the best.
Couldn't
so.
even think of doing this meeting without you.
Thanks a
a lot,
lot,
man.
Appreciate it, Eric.